Okay, welcome everybody. I hope you can all hear me. My name is Phil David. I'm the Executive Director of Adath Israel Synagogue Congregation, and we're very, very pleased to welcome you all here tonight. We have well over 220 that have signed up for this, so we're really excited to welcome Dr. Brian Goldman. A little bit of housekeeping before we start. You'll see, depending on where you're looking, the woman that's on our screen, Sarah McGoldrick, is our social media coordinator and the brains and technology behind all of these sessions that we're doing, Sunday night and otherwise. Sarah is going to be helping me with the back end of tonight, but also is the moderator. And so if you have questions that you'd like to ask, you'll see a Q&A feature on the bottom of your screen. You can certainly send questions through for Dr. Goldman through to Sarah using that Q&A feature. One of the other things that we probably have heard of over the last few weeks since Zoom became very prominent is that there are security breaches out there where people come in Zoom bomb and show inappropriate images. If that happens, I'd ask you, please don't hang up. We're monitoring very closely, and if we find someone does Zoom bomb, give us a few seconds so that we can actually kick that person out. Failing that, if we're not able to do it, we'll end the meeting and we'll immediately send a new link to all of you through the email that you provided. But hopefully we've set this up so that won't happen. So enough of the housekeeping. We're going to turn this over to our senior rabbi, Rabbi Cutler, to do some quick introductions.
Good evening, everyone. It's wonderful having all of you here this evening as we continue in our Sunday online speaker series. We are very excited to have with us this evening our member, Dr. Brian Goldman. Dr. Goldman is a highly regarded emergency physician at Mount Sinai Hospital. He's also the host of CBC's award-winning radio show and one of my favorites, White Coat, Black Art, where he takes listeners behind the scenes of hospitals and doctors' offices. You should know that his TED Talk, and I'm a little bit jealous here, Doctors Make Mistakes, Can We Talk About That?, has been watched by close to 1 million viewers, which is to say 999,500 more than watched my video this past Friday. He's been featured across media platforms as a medical specialist, and it's really our pleasure to have him here with us this evening. Thank you, Dr. Goldman, for being here. I turn it over to you.
Thank you, Rabbi Cutler and Phil and Sarah. It is it's a pleasure to be speaking to you. I have to say that the circumstances I wish were different, and I wish I could meet you in person. I've met many of you before. I said Kaddish in the chapel for almost 2 years consecutively, and just ask people there, and they will tell you all about that. Now, I'm going to talk about, obviously I'm here to talk about COVID-19. I want to get to the questions that you have. I've decided to frame my remarks by answering the questions I think you want to know the answers to. I'm sure you're going to have more questions. Jot them down and send them in to Sarah in the Q&A feature, and she will curate those and bunch them up into similar questions and fire them off to me. Before I start speaking, I want to let you know that if you're looking for exact, perfectly correct, scientifically true answers, I want to give you a huge caveat here before we begin. We're dealing with a brand new pandemic virus, the coronavirus, and unlike influenza and unlike SARS, which took a long time to understand, we're just beginning to come to grips with it. Learning about things like the incubation period, the typical symptoms, the atypical symptoms, the complication rate. But there are many, many, many unanswered questions. And when I say unanswered questions, I mean not scientifically validated. Ordinarily, what we like to do is to look at scientific studies that have been peer-reviewed, which means the scientists who do the study on the virus, in this case COVID-19, or the treatment for the virus, like chloroquine or remdesivir, what they will do is they will do a controlled clinical trial. They'll do a careful paper. It will take weeks to develop the study, months or years to do the study, and then they send it off to a journal like the New England Journal of Medicine or the British Medical Journal for a peer review, which means that the paper in a draft form is sent out to several learned people who then critique the heck out of that paper and then send it back. And sometimes it takes many revisions. That process can take years. Well, we don't have years because we have a pandemic. And so what I'm going to give you is what we know on the fly, which means almost anything I say can be contradicted by upcoming evidence. And what I would ask you to do is cut the public health specialists and the epidemiologists, the population specialists, the infectious disease consultants who are trying to keep us up to date, kind of a bit of slack, because whatever they say today may be wrong in a while. Example, masks. For a long time, a lot of people said, don't wear masks because they're not going to make any difference unless you have COVID-19 or you're a healthcare provider and you're at risk of being exposed to COVID-19. And you may have remembered reading when the head of the Public Health Agency of Canada, Dr. Theresa Tam, did what some people thought was an about face and said, you know what, we said you shouldn't use masks and now we're saying maybe you should use masks. And that's not my jumping off point, it's my caveat. It just means be careful about pinning people down to exact facts. The more sure somebody is about the coronavirus, the less I trust them. I actually like it when people can live in the world of uncertainty and can say, you know what, we're not sure. I really trust the people that say we don't have all the answers yet. And so before I start trying to answer some of these questions, I just want you to be aware that there's a lot of uncertainty here, and it will become more certain in the weeks and months to come. So let's start with what we know so far about COVID-19. We know that COVID-19 is caused by a coronavirus. That's certain. That means it comes from exactly the same family as the virus that caused SARS, severe acute respiratory syndrome. I was on duty at Mount Sinai Hospital at that time back in 2003 when it happened, and another respiratory syndrome called MERS, which is Middle Eastern respiratory syndrome, and that happened a few years after that. Researchers believe that it came from China because the city of Wuhan in Hubei was the first place where there was a reported outbreak, and a massive one at that. Now, I have this other show in addition to White Coat Black Art. It's called The Dose, and you can visit The Dose and subscribe to it at cbc.ca/whitecoat. And every week we try to bust a myth, provide some useful information about health issues that people care about. But in the last 2 months, not surprisingly, we've done most of our shows on COVID-19. On that show, a couple of weeks ago, we had Jason Kindrachuk, who's a medical microbiologist at the University of Manitoba, and he said that it's highly improbable that the virus comes from a lab. I know you may be hearing other things about that right now, but that's based on a study that was published in the journal Nature in March. And it concluded that the virus was not created in a lab or purposely manipulated in some other way. So where does this virus come from? Well, we're not sure. Like many of the questions that we're going to ask, a lot of the answers are we're not sure. But the virus that is causing COVID-19 is almost identical to a coronavirus found commonly in bats. There's no evidence that it was genetically engineered to be particularly harmful to humans, but if you compare the coronavirus, a particular coronavirus that infects bats, and compare it to the coronavirus, the COVID-19 that's infecting human beings around the planet, they are 99.9% similar. So they think it came from bats. They don't know, researchers, how it went from bats to humans. We call that jumping species. Either it went directly from bats to humans, or it passed through a mammal on the way to humans. In other words, it started to be infectious in mammals and then it infected humans. But that's what we know right now. We think it came from bats. We don't think it came from a lab. Now, what are the typical symptoms of COVID-19? I think you know a lot of these. Fever. And one of the interesting things about COVID-19 is that not everybody has a classic set of symptoms. Some people will have the symptoms, some people won't. The most common symptom is fever. About 44 to 99% of patients have fever. Between 22 and 83% of patients, depending on the study, have a cough. Most patients feel extreme fatigue or punkishness. We call that malaise. Headache is fairly common. Shortness of breath occurs in people who are seriously ill with COVID-19. Sore throat can happen, or a scratchy throat, but it only happens about 20% of the time. Runny nose is very unusual in COVID-19. So typically, if you've got runny nose, you probably don't have COVID-19. You probably just have a cold or one of the other viruses that can cause that. Some patients lose their sense of smell. And at first, doctors didn't believe that could happen. Now we know that that's one of the symptoms, the potential symptoms of COVID-19. Some develop diarrhea, particularly children, nausea and vomiting. And frail seniors can become confused and delirious and altered mental status, altered awareness, people who no longer know what day it is or what time it is or what month it is, but knew those things 2 days ago. That can be a symptom and a sign of COVID-19 in frail seniors. Now, I've talked about the typical symptoms, but you probably already know this. Between 20 and 90% of people who get COVID-19 have no symptoms whatsoever. And either they are completely asymptomatic, which means without symptoms, or they have very few symptoms, and then they get something more recognizable as COVID-19. We call them pre-symptomatic. And one of the things about SARS that made it so easy back in 2003 to pick out people who had it is that if you were infectious with SARS, if you were at risk of infecting other people, you had symptoms of SARS. You had dry cough, you had a high fever, and you were short of breath and you were sick. Whereas with COVID-19, even if you're destined to get symptoms, you can have no symptoms whatsoever for the first couple of days before you have obvious symptoms of COVID-19. And during that time, you can infect other people. But you can appreciate if there's a significant chunk of people who get COVID-19 without symptoms, it's hard, almost impossible to trace contacts, to know who you got it from. And that's one of the reasons why we think it's been able to spread in some places more than others, the prevalence of asymptomatic people who are able to spread it without knowing that they've even got it. What's the prognosis for people with COVID-19? Well, the vast majority of people, I want to say this slowly, the vast majority of people infected with COVID-19 require no treatment, no specific treatment other than bed rest and Tylenol, and they get better. 15% are sick enough to require admission to hospital. 5% are so sick that they need an intensive care unit, and many of them need a ventilator. So it's not something that's going to happen commonly, that you're going to be seriously ill. But of course, with all the media reports of people who become very ill, who end up on a ventilator, talking about what it's like to recover from a ventilator, grieving the loss of somebody who's died while being on a ventilator, it's easy to get the impression that everybody gets really sick and everybody dies. It just doesn't go that way. We think that depending on the country, the chances of dying if you're infected with COVID-19 are anywhere from about 0.5% to 1% on the minimum side to maybe 5 or 6% on the maximum side. But this is a very important but. That's based on data that we have of the people who died as a fraction of the people who have confirmed COVID-19. Now, you've probably already heard that we're not testing enough people in our society, in Ontario, in Toronto, for instance. If we tested everybody, then we know the deaths because everybody's death is recorded. There's a death certificate, and that's a matter of public record. But what we don't know are the number of people who actually have COVID-19. My point is that we could say that today the chances of dying from COVID-19 based on the number of confirmed tests is 2 or 3%, which sounds like a lot, 2 or 3 out of every 100. However, if we were to test everybody, we might find that there's another 10, 20, 30, 100,000 people who have COVID-19 and no symptoms. If you added them to the total number of people with COVID-19, that percentage of 2 to 3% might drop to 1 in 1,000. So that's why it's very hard to try to peg your chances of dying. But even at 2 or 3%, the vast majority of people recover. Now, there are people who get sick with COVID-19. They tend to be older. They tend to be over the age of 70 or 80. They tend to be smokers. They tend to be people with poorly controlled high blood pressure, diabetes, asthma, heart or kidney disease, and they tend to be sicker. And so doctors recommend that if you have high blood pressure or diabetes, you want to make sure, or asthma, that you're up to date on your medications and that your blood pressure, your blood sugar, and your asthma are under the best control possible so that if you do get infected, you're less likely to suffer a serious case of COVID-19. You've heard the expression flattening the curve. What the heck do they mean by that? Well, COVID-19 is a brand new virus. And that means that until the outbreak first occurred in China, it had never happened in the history of the human race. Nobody had ever been infected before. And if we let the virus run wild in Canada, for instance, in Toronto, in Ontario, the United States, or anywhere else, experts believe, and this is a staggering figure, that because none of us has ever had it before, we're not immune to it, we don't have even cousin antibodies that would recognize it, that if it infected all of us at once, or it spread like wildfire across the population, that 50 to 60 or even 80% of us would become infected with COVID-19 in a very short period of time, in weeks or months. If that were to happen, then the peak of infections would look like this. And it would overwhelm our healthcare system. It would overwhelm our intensive care units, our emergency departments. It would overwhelm the number of ventilators that we have, the number of intravenous that we have, the number of people that we have to look after those who have COVID-19. And so authorities, starting with public health experts, said we can't do that. So flattening the curve means slowing down the rate at which Canadians are infected, so that we have enough hospital beds and ventilators to take care of everyone who needs them as we need them. So that curve, instead of looking like that, would look like that, a nice flat hill, something that's a little easier to climb. And if you look at what's happened in Ontario, particularly in hospitals in the Greater Toronto area, we've done a good job. I can tell you that emergency departments are fairly quiet. That we have seen, we've got probably 200 patients right now across the entire province that are on ventilators. That's not an overwhelming number. We procured enough extra ventilators, so that from that standpoint, we're handling things really, really well. And that's a tribute to you. It's also a tribute to the healthcare system and to the people who run the healthcare system. What do we mean by physical distancing, and why are we doing it? COVID-19 is found in droplets of saliva, nasal discharge, and phlegm of people who are infected. You get infected with COVID-19 if someone with infected droplets coughs on you, hence you want to cough into your sleeve, or sneezes on you, hence you want to sneeze into your sleeve, or if they spit on you. If an infected person coughs or sneezes onto a countertop or a doorknob, or if their hands are kind of wet because they sneeze into their hand and then they touch a surface, they touch a doorknob, they touch a telephone, then that surface can be infectious. It can have virus on it for anywhere from some minutes to hours, or maybe even a day, depending on the surface. That means that if you touch that surface, if somebody walks along and touches that wet surface and then touches their eyes, their nose, or their mouth, then they can become infected, and that's how it happens. Now, one of the good things that we know about the virus that's on surfaces is that it doesn't make more of itself. This is not a bacteria. Bacteria multiplies on a surface, which means it makes more infectious material, whereas a virus doesn't do that. So whatever's there is there until it dies, and when it dies, and it doesn't make more of itself. So that's probably good news. But now you can begin to understand the physical distancing rules. The reason why you don't go to shul or congregate in large groups is to decrease the chance that you'll meet somebody in that group of 100 or 150 or 200 who has the infection. So you're just geometrically increasing your chances of getting infected because somebody there is going to have it. And it's not a surprise that some of our major outbreaks of COVID-19 have occurred either in small plants like meat packing plants where people are congregating together in close quarters, or parties, gatherings in a park, indoor gatherings in particular. And that is why authorities said we have to put a stop to that. Otherwise, this is going to spread like wildfire, and you're going to have that big curve that I told you about. We clean surfaces frequently in case someone sneezed on virus. Somebody who was infectious sneezed on the surface, and now it's infected. So if I touch it and touch my eyes, I could become infected. So we wipe the surface down with Clorox, with one of the hand sanitizers, or one of the hand wipes. And we keep surfaces clean because we can't watch it constantly. So we have to be able to do something to try to assure ourselves that that surface that I'm about to put my food on or touch isn't teeming with viruses. We wash our hands frequently because you never know when you accidentally touch a surface that was infected. You don't want to put that in your eyes, nose, or mouth. And we also wash our hands frequently in case we've touched a surface. And so you begin to understand. So I want to say that one more time so that you get the chain of events. Infected person coughs or sneezes on a surface, then walks away. The surface is still wet with whatever secretions. You touch the secretions and then touch your mouth, your nose, or your eyes, and you can become infected. So now you understand, if I'm the perpetrator, I cough or sneeze into my sleeve, my elbow, so that I don't put it on a surface. Somebody comes along and wipes the surface frequently to keep it clean of virus. I don't touch those surfaces, but if I do touch those surfaces, I wash my hands frequently. And the last thing is I never touch my eyes, my nose, and my mouth, because if you do that, then that's the last step in the chain, and you could become infected. Next question I want to ask you: is it safe to go to the emergency department? Yes. Before I say anything else, if you have a true emergency, either go, or if it's that urgent, call 911. The kinds of emergencies that we would routinely expect to see: belly pain that doesn't go away with a bit of Gaviscon or a Tylenol, a headache that doesn't go away with Tylenol, particularly the sudden headache that's the worst headache that you've ever had in your life. If you have the symptoms of a stroke, for instance, if you suddenly can't talk or you can't move your arm, or you're confused, or somebody notices that you're confused, or if you have severe chest pain or severe shortness of breath, any of the typical emergencies, don't think twice about calling the emergency department or calling 911. We know how to handle this situation. And the reason I'm mentioning this is that anecdotally, right across the United States and Canada, patient volumes at emergency departments are down by 20 or 30%. A survey by the American College of Emergency Physicians found that a significant percentage of Americans would avoid or postpone a trip to the emergency department. We don't have similar data in Canada, but when, I've been on duty in the ER, and when we ask patients, especially the patients who had severe belly pain for 3 days when we think they should have come in on the first day, why didn't you come? They answer, I was afraid. I was afraid that I might get COVID-19 in the emergency department, or I was afraid that you'd tell me I need to be admitted and I'd be separated from my loved ones, and I don't want that to happen. So the point I'm trying to make is that you could have a terrible outcome if you wait. I have seen patients who have a burst appendix. That means a perforated appendicitis. And usually most people who have appendicitis come in the first few hours because the belly pain is really severe. But I've seen people who have waited extra a day or two. The longer you wait, the more likely the appendicitis is perforated, which means you're going to have a much more complicated illness. Or somebody who has a twisted gut, a twisted intestine, and the blood supply to that portion of their intestines is in jeopardy, and they wait and wait and wait, and that's a very serious problem because they can have several feet of dead bowel when you open up the belly to treat them. People with strokes, what doctors are finding is that they're not coming in with the typical symptoms of a stroke, they're coming in much later. That's bad news because we can do things to reverse a stroke immediately if you come immediately, or a heart attack for that matter. We want to do an angioplasty within 90 minutes. We don't want to do, we don't want to start treating you after you have a completed heart attack. We want to treat you in the earliest stages of the heart attack because time is heart muscle, and the faster we get to it, the faster we can get you feeling better. So the question is, how safe is the emergency department? It's very safe. We have plenty of personal protective equipment, PPE. We have the masks, the gowns. We know from the first moment that you arrive either by ambulance or walk in, the triage nurse is going to be asking you, do you have a fever? Do you have a cough? Do you have shortness of breath? And if they think you have even a slight chance of having COVID-19 or anybody else, they put a mask on you and put you into a special room. We have no data of anybody in the history of COVID-19 who's been infected with COVID-19 by coming to the emergency department. So the bottom line is, come to the emergency department. Next question. Hospitals have put off elective surgeries to focus on fighting the coronavirus. And how concerned are doctors about dealing with the massive backlog once the immediate COVID-19 threat is reduced? Now, I can't see everybody on this Zoom talk, but I know that there are people listening to us right now who have had hip and knee replacements that have put on hold, cataract surgery put on hold, even cancer surgeries have been put on hold. And doctors are quite concerned about postponed surgeries and other treatments for a number of reasons. Why was the postponement done? The idea was to increase the amount of space in the hospital for people with COVID-19 and increase the physical distancing within the hospital, and to protect vulnerable patients who had to be in hospital, who, if they got infected with COVID, would have a more severe case and might even be at risk of dying. Now, what did they do? How did they decide who gets surgery and who doesn't during the time of COVID? To do that, they drew the line at life or limb. So I'll give you an example. I spoke to a vice president at Toronto General Hospital, University Health Network, and he told me that they drew the line at 14 days life or limb. What that means is that the surgery would go ahead if the patient was at risk of losing their life within 14 days, or their limb, their leg, their arm, or a vital organ like a kidney, a lung, a heart, a brain, an eye, your vision, for instance. Now, that's an arbitrary cutoff. That's a very austere, very severe cutoff. What about a patient at 21 days from losing their life or limb? Well, that patient could escalate from 21 to 14 days in no time, or maybe 7 days later, they are at 14 days. So if you have an arbitrary cutoff like 14 days, you have to watch those patients very carefully. Toronto General says they've been doing it. I take their word for that. Then you have the patients who may be 1 month, 2 months, or 3 months from dire consequences. How do you keep track of them? Well, you have to call them every week. Maybe you have to bring them in for testing, blood testing, for lab testing, to see just where they are on that curve. So there is a serious problem of monitoring the people whose urgent procedures maybe aren't quite at life or limb, but could become that way. Then what are you going to do about the backlog? And it's been estimated that 100,000 Canadians right across the country have had their surgery postponed, and they're waiting. And working through that backlog is going to require a gargantuan amount of work and vigilance by people in hospitals. And they are forming committees to try to figure out who goes to the top of that list and who's next after that. It's going to be a big job. And it's something that we've covered on my show, White Coat, Black Heart. What are the treatments that are available for people with COVID-19? Doctors are using drug treatments, and there are even published recommendations of drug treatments in Canada, in the United States, in the European Union, and they talk about drugs that you've heard of, drugs like chloroquine and hydroxychloroquine that work on the immune system. There are also drugs that we hope will work on the coronavirus itself. There's been talk, including by Dr. Anthony Fauci, who's the head of the National Institute of Allergy and Infectious Diseases. And of course, he often speaks on White House policy in the United States. And he's been talking, and many people have been talking about a drug called remdesivir, which is an antiviral drug which was developed originally for the treatment of Ebola. And since the pandemic, it's been studied as a possible treatment for COVID-19. And preliminary results of a clinical trial by the US National Institutes of Allergy and Infectious Disease, which happens to be the agency that is run by Dr. Fauci, it found that remdesivir cut the duration of symptoms from 15 days down to 11 days. So it shortened the illness by 31%. So it's a 4-day reduction in the duration of the illness. There was also an insignificant decrease in the chances of dying. When I say insignificant, I mean it has to be as statistically significantly possible. So it has to reach statistical significance, and I'm not going to talk about that at length, but what that means is that if it is statistically significant, it means that the difference in the death rate can't be explained by chance alone. So this result did not reach statistical significance. We're going to have to do other studies. So we don't know right now whether it reduces the chances of dying from the coronavirus. Dr. Fauci said the data shows that remdesivir has a clear-cut, significant positive effect in diminishing the time of recovery. And he said, and other people agreed, that it has become standard of care, that people are going to receive remdesivir if they're sick enough to be admitted to hospital. Now, what we don't know, there are problems with the way that data was rolled out. It was not published in a study. We haven't been able to look at the data, and it hasn't been peer reviewed. The reason why it was rushed to be announced in the United States and in other countries was because of the importance, the fact that we don't have treatments for coronavirus. People who have been studying infectious diseases for decades now, going back to HIV and earlier, will tell you that many a drug is rushed into use, and it turns out that there are some deadly side effects. And chloroquine is a very good example. Chloroquine is a drug that is used in other diseases. Hydroxychloroquine is used it's Plaquenil, and it's used in the treatment of inflammatory conditions like rheumatoid arthritis, and it has a place there. But it's a drug that can cause heart rhythm disturbances, and we certainly don't want people to be taking these medications outside of a clinical trial, except for remdesivir. And that's for people right now who are sick with coronavirus. What we don't know is whether giving people medications at the first sign of coronavirus, like in the early stages, or even people who have no symptoms, could it keep them from developing a serious disease? Could it help prevent it? We don't know the answer to that, like a lot of other things. How are we doing in flattening the curve? Well, let's concentrate on the situation in Ontario. Health officials reported earlier today that there were 434 new cases of COVID-19, which is a slight drop from 511 announced on Saturday. The total number of confirmed cases of coronavirus in the province stands at just over 17,000. 12% of those patients have been hospitalized, and currently just over 1,000 are admitted to hospital. That's an increase of 33 over Saturday. An additional 40 people have died in the last 24 hours. What we have here calls for cautious optimism. Authorities believe that we are at or just past the peak of COVID-19, but for officials to declare that the first wave is on its way out, they would need to see a consistent pattern of decreased cases over a 14-day period. So stay tuned. You never know. In some provinces, Quebec is a good example. They saw a decreased number of cases and it started to go up again. And so we have to be very careful before we declare that we're past the peak. What they're looking for is that evidence of each new case of COVID-19 does not lead to 2 or 3 more new cases. And we saw that in the early days. We saw it in Italy, we saw it in Spain, and we saw it in parts of China before they started to lock down the country. What we want is the opposite. We want to see through the data that each new case results in no more than, say, half a new case or 0.7 new cases, which means, that doesn't mean that a person spreads it to half a person. That's silly. But that there are people out there who get the infection and don't spread it to anybody, because they're washing their hands and they're in quarantine, in isolation, and everybody's practicing the physical distancing that we want to happen. To know that we're moving in the right direction, we need to be doing much more testing of people with the virus and the people that they come into contact with. And quite frankly, we're not doing enough testing right now. And that is a serious concern in many parts of the United States, where they are starting to open up the country to business and reducing physical distance, and they don't know where they are on that curve. Are they on the happy side, or are they on the unhappy side? Is it a flat curve? Is it a sharp curve? We don't know. Have there been any new developments on a vaccine? There is cautious optimism that a vaccine candidate being developed by researchers at Oxford University will be effective and safe. The vaccine's being tested as we speak in human volunteers. And this week, Oxford announced, that's the university that's developing it, they're teaming up with the pharmaceutical company AstraZeneca in the hopes of speeding up the development and spreading out the financial risk. The collaboration aims to bring patients the potential vaccine within a year, it could be January. I have to tell you that the fastest vaccine for a virus in the history of vaccines took 4 years to develop. And if it happens in 12 or 15 or 18 months, it would be fastest by far. Now, the vaccine is developed, and then the next question is who gets it? Philanthropists like Bill Gates are so optimistic that they're urging wealthy countries to start planning for equitable distribution of an effective vaccine if and when it's available. Gavi, which is the world's leading international immunization nonprofit organization, and the One Campaign advocacy group are joining the Gates Foundation in the push for a plan. And over the weekend, Sir John Bell, who's a Canadian immunologist working on the Oxford University vaccine effort, predicted that if it's successful, the vaccine he's working on will need to be given once a year, just like the flu shot. That's because the coronavirus, the COVID-19 virus is mutating, not too quickly, but quickly enough that the vaccine you have today would probably not be effective in 2 or 3 years. What's going to happen next? It's the last question I'm going to ask, and then I'm going to ask myself, and then we're going to open it up to your questions. This is just my prediction. I'm spitballing based on what I've been seeing and what we know about the virus. My prediction is that as the weather gets warmer, as it was today, more people are going to head outside, and increased pressure will be placed on the province and on the city to reduce physical distancing measures and economic activity. I hope if and when that happens, it is accompanied by increased testing, because we have to know what's happening very quickly. Otherwise, we could find ourselves heading back up that curve once again. But know this, whatever we do, testing or not, we will, as we open things up, we will see an increase in the number of cases of COVID-19 and an increase in the number of people who get sick, and unfortunately an increase in the number of people who die. You can count on that, unfortunately. The idea, once again, flattening the curve doesn't mean it's over, Beseder Gamur. It means that we have slowed it down, and that's the end of the first wave. We've controlled things so that we haven't overwhelmed the healthcare system. So that's one of the major reasons why we're doing it. A few weeks ago, the head of the US Centers for Disease Control said we might see 1, 2, 3 waves of COVID-19. And if you look at the curve 100 years ago on the Spanish flu, that is exactly what we saw. And I think the next peak may occur, as the head of the CDC said, sometime late this year or early in 2021, when we have not only COVID-19, but the flu. And the two of them together could be a double whammy. And, please God, it doesn't happen, but we have to be ready for it. And those are all the things I prepared that I want to talk about. Happy to answer your questions now.
Okay, hello, everyone. Thank you for joining us tonight. I think the first question we'll get to, which has been asked over and over and over again, and is really the most important question: when can Zadie and Bubby see their grandkids again?
I was afraid you were going to ask me that question.
Get it out of the way.
Well, and it is a really good question. And there's a couple of things. There's a couple of ways that I want to begin to give you some hints. When it came to SARS, that coronavirus, when it disappeared, it was gone. And I think that if we do, and this is why everybody needs to be clamoring for testing, because the more testing we do, the testing over a wider population, the more we do that, if we actually see no cases of coronavirus for 14, 21, 28 days, then I think then you're going to hear public health specialists speculating that it's gone, at least for now. And if it's gone for now, and if we are vigilant as to who's arriving from countries that might be carrying it and putting them into quarantine, not guessing, saying you must go into quarantine, then I think you're going to hear them say it's safe for Bubby and Zadie to see their grandchildren. But we need data to get that answer, without which we're going to be speculating. And unfortunately, Bubba and Zeta are at the greatest risk of succumbing to the coronavirus, which is why we're so concerned about not opening the floodgates without data.
Because we're also getting questions like, well, if the kitties are asymptomatic and we're asymptomatic, Can we still see them? Clearly the answer is no.
Yes, no, if it's around, if the virus is around, and the reason why is that you cannot judge whether somebody has COVID-19 by whether or not they have symptoms, because we've seen now, it's startling. There are some studies where 70–80% of the people studied who tested positive for COVID-19 had no symptoms whatsoever. And you could say, well, I'm okay. But that grandchild might have coronavirus and might be bringing it to Bubby and Sadie. So you just can't. You have to follow the advice of public health specialists, and that doesn't now if there is a silver lining at some point. Now remember, when does this come to an end? It comes to an end when there's a vaccine. When everybody gets a vaccine, then you can go out and hug and kiss your grandchildren to your heart's content. The other thing is, you may hear about something called an immunity passport, which is all about people who, what about people who've been infected? And we're in the early stages of developing a reliable antibody test. Remember, when you're exposed to the virus, your immune system fights it off and you develop antibodies. If you have antibodies, if you're a grandparent who has antibodies to the infection, that means you got it. And authorities believe that you're probably going to not get it again for at least a few months afterwards. So during that interval of time, you're probably protected. But again, this is like all the things that we don't know complete answers to right now. And that's because this coronavirus is so brand new. Next question.
Okay, and then the last question, maybe on the kids for a little while. Can you talk a little bit about what the COVID toes are? That's kind of new in the news.
Yeah, COVID toes. Yeah. So the thing about COVID-19 is that it seems to cause the platelets which are the little cells in your bloodstream that form clots, and that's good because if you cut yourself, you want the bleeding to stop, and one of the ways it stops is by clotting. But we believe that the coronavirus causes clots to form more readily. The platelets become stickier, which puts you at increased risk of heart attacks and strokes and blood clots on the lungs and blood clots in the toes. And those are the COVID toes. It's yet another one of those associated symptoms and signs. Lately on social media, I've been reading that it may not be that reliable a sign, but it is something that we're noticing and paying attention to.
If a person's returning back to work and they want to wear a reusable mask, do you have a preferred brand or type, or what's your suggestion when it comes to masks?
Yeah, so we had Jason Tetro, who's the germ guy. He writes. He's a medical microbiologist and a popular author, and he was on our show. He was on The Dose last month, and he says that you could make your own mask out of a t-shirt. In fact, that's all you need to do. But the most important, so it's not, the cloth doesn't matter. If it's cotton, it's fine. If it's synthetic material, it's fine. What you need to do is wash it, because if you just keep using it and using it and using it, it's not the virus, it's the bacteria that will be coming from your mouth, for instance, that from the saliva in your mouth that can now infect that. So you have to clean it regularly. But my point is, you can buy any reusable mask that's sold, but just make sure that you clean it regularly.
Given that the antibodies may not last as long as we'd like, you can go for a flu shot and it lasts you a while, or a measles shot and it lasts you your whole life. What's sort of the time span on a COVID vaccine, or do we just not know?
Yeah, so that's a good question. Certainly the Oxford University candidate, there are others as well, but I'm going to mention the Oxford University candidate vaccine because it's the furthest along in development, and it's the one that they've got a lot of hopes on. There is it attacks a protein which the virus uses to puncture cells and gets into cells. And so the idea is that you get this vaccine, and as soon as the virus comes in, the antibodies produced by the vaccine will recognize that part of the virus, the puncturing part, and it will grab onto it and take it out and remove it. The problem with the coronavirus is that it changes, it mutates, not that rapidly, but somewhat rapidly. So Sir John Bell, who is one of the lead researchers on that particular vaccine, believes that the protection would last a year. And the reason why it would last a year is that by the time you came to the next year, so let's just say you got the vaccine in the middle of 2021, it would work until 2022, because by then the coronavirus would have mutated so much that the antibodies produced by that vaccine would no longer be effective against the latest version of the coronavirus. So you'd probably have to get an annual vaccination in the same way that you get an annual flu shot. You probably know that annual flu shots also mutate, or not flu shots, but flu viruses that circulate mutate fairly rapidly. And so as a result of that, it means that a flu shot that you get this year probably won't protect you. It may protect you against next year's flu. It won't protect you against the flu from 2 or 3 years down the road.
Now it's taking 4 or 5 days at a time sometimes to get your test results back. So if you get tested, should you then just stay inside and wait for your answer, or?
Yes, that's a really good question. And I can tell you that public health officials, like public health workers, frontline public health workers, are run off their feet. And this is part of, the province of Ontario did 17,000 tests in the last 24 hours, which is the largest they've done yet. It's fantastic. The problem is that it's not just the test kits, the swabs, but also you have the labs, and you have the people who trace the contacts. And there's a lag in that. And 4 days is not unusual, and it's unfortunate. But yes, the short answer is you have to assume until you get the all clear that you are infected, and you have to remain in self-isolation because of that. Which means that if you live with somebody else, you should stay in your part of the house, in your own room, and don't share the same drinking glasses. You can watch TV at the same time, but you should be walking around your house or apartment wearing a mask.
And what should someone who's got a compromised immune system, like what extra steps should they be taking? And can you, like in the briefest terms, define what a real compromised immune system is? Because we've seen all kinds of Facebook posts saying this person is or that person is. What does it really mean, and what should they be doing?
So in really simple terms, a compromised immune system occurs either because you were born with a defect in your immune system that makes you susceptible to infections, or you have HIV, or you have you're on medications which deliberately dampen or reduce your immune response. So people who've had kidney transplants or lung or heart transplants who have anti-rejection drugs, people who are on certain cancer chemotherapy drugs, people who take biologics for rheumatoid arthritis, for Crohn's disease, and for other autoimmune disorders, they have an acquired immune deficiency. And so as a result, so those are the people who have an immune deficiency. What do you do if you have one? If you have one, you are somebody who is at great risk, if you get COVID, of becoming really sick. So that means that you should probably wear a mask in your own house, especially if you're around other people that are coming and going. And certainly if you're out and about, if you have to go to the hospital for tests, then you should be wearing a mask. And the people who are around you, who live around you, must take special precautions. That means they should be wearing a mask if they go to a supermarket to get groceries for you. They should be taking care not to be meeting lots of people, lest they bring the infection into the house. But that's the biggest danger, that somebody you know and love will bring the infection into the house.
So building on that, should everybody be wearing a mask to the grocery store at this point? And what level of cleanliness, like how much should we be washing and wiping down our groceries once we get them back home? Okay,
so let's start with the mask. For a long time, there was no recommendation to wear a mask if you were just out and about. Now that has changed. And at this point, you don't have to wear a mask, but it is recommended. And the purpose of wearing that mask is that if you're sick, you're not going to spread the germ, you're not going to spread the coronavirus to other people. And you're also reducing the risk that if somebody else comes into your close vicinity, say within the 2 meters, and coughs or sneezes, that you're reducing the chance of acquiring the infection from other people. So you should wear a mask, as we've talked about. It can be made from a t-shirt, an old t-shirt. It can be made from a sheet or like an old pillowcase, just cut to size, but just wash it frequently. Keep it clean. Now, what about cleaning surfaces? Always remember what you're trying, the chain of events that you're trying to intercept and prevent. You're imagining that somebody was sick and touched the food that you're about to pick up in your hands. And you're going to put it in your mouth. Well, first of all, if it's anything that you peel, all you have to do is wash the surface. If it's a banana or an orange, then once you peel it, whatever's inside wasn't infected, because there's no way anybody touched that. Okay. If you're bringing prepared food into the house, if it's cooked food, the cooking killed the virus. So that's great. So now it's all wrapped up. So what do you do about that? You bring it into the house, you wash the surface completely. And if you want to wear gloves while you do that, you can do that. Take the gloves off, peel off the wrapping, and everything that inside is not contaminated at all. All along the way, don't touch your nose, your mouth and your eyes, and wash your hands frequently.
And how safe is it to get takeout at this point?
Unless and until I hear about an outbreak that started from takeout food, I'm going to assume that it's safe, because if it's hot food, it's cooked. So first of all, it shouldn't have virus in it, even if somebody sneezed on it, which we hope doesn't happen. So it's cooked. The cooking kills the virus. Now it's wrapped up. In the off chance that somebody has contaminated fingers, they touch the surface, not the food, but the surface itself, the wrapping, and all the preparers of takeout food are being very careful. So what you do is it arrives in the house, you wipe it all down, you wash your hands, open it up, and it should not be contaminated in any way, shape, or form. It should be okay.
Are future waves inevitable?
Yes. Are future waves of the coronavirus inevitable? Yeah, I think they are, for a number of reasons. I think we have to be practical. I think that Canadians, Torontonians have made a tremendous sacrifice to take us to this point in time of flattening the curve. And I think we've done a really good job of flattening the curve. But the at great expense, at great price to the economy. And today, I'm sure you walked outside and you thought, it's spring, it's beautiful, it's 21 degrees, I'm out of here. And now, I'm glad, I hope we didn't see groups of people congregating at the beach or, at Scarborough Bluffs or in parks. But clearly, there's going to be some letting go. And that means that we're going to get a little bit careless and this virus, remember, flattening the curve does not mean ending it. If this is a brand new infection, it means that until there's a vaccine, we are not going to be safe from it until something like 80% of the population has been infected or has been vaccinated. So we're buying time for a vaccine, but until there's a vaccine, you can be sure that just by chance alone, there are going to be people arriving from another part of Canada or from another country who have the infection and who are going to inadvertently infect other people. And we have to be prepared for that.
Does a flu shot or any other kind of shot help lessen the severity of this or reduce your chances of getting it, or is it simply its own entity?
Okay, so first of all, it's its own entity. The short answer is it's its own entity, and a flu shot will not protect you from the coronavirus. But know this, could you be co-infected with the flu and coronavirus next winter? Yes. So getting a flu shot will protect you from the worst consequences of the flu, so that if you happen to get coronavirus at the same time, you'll be less likely to get very sick. So we want you to get your flu shot.
When you're walking your dog, should you be wiping his paws when he comes in?
it depends on where your dog has been. I suppose that if you saw somebody sneeze on a park bench and your dog touched the park bench, exactly where oh, I see the cat. That's nice. I have a budgie upstairs. She's great. She hasn't said a word. Now, so I'm being a bit facetious here. If somebody sneezed a whole wad of sneeze on a park bench and the dog touched it, you should wash the dog's paws. Otherwise, forget about it. Don't worry. That's the likelihood of being infected that way is almost zero.
We're not animal experts, but I would assume just use like soap and water meant for animals, no Lysol wipes, nothing strong, just, yeah.
At home, we use soap and water most of the time. And the secret of soap and water is to get and that's to wash our own hands, to get a huge dollop of soap and scrub because it's the mechanical action of the scrubbing that takes the virus off your hands. And you can sing, I'm sure that you can sing Hava Nagila, but Happy Birthday will do. At least 20 to 30 seconds of this kind of friction will take care of the virus. And then of course, rinse it in the sink.
What level of effectiveness do you see the vaccine reaching with people? Will it work for everybody, or is it, what's usually like for viruses or vaccines in general?
Yeah, that's a great question. And there's minimum and there's maximum figures. The best vaccines we have are for the common childhood diseases like measles, mumps, rubella, whooping cough. Measles vaccine is about, I think, 85 to 90% effective. And with a booster, they can boost it up approaching over 95%, which is enough to, if you vaccinate the vast majority of the population, it's enough to prevent measles outbreaks. Flu shots vary from year to year. Sometimes they're as poor as 15% effective, and sometimes they're 60% effective. And we only know year to year by doing surveillance studies to see when people got their shots, how well protected they were. So it really depends. I would hope that the vaccine against the coronavirus would be at least 50 or 60% effective. And even if it didn't prevent you from getting the illness, I would hope that it would substantially reduce your risk of dying from coronavirus should you get sick.
Okay, and here's a two-part for you. Do you see summer camps happening in a few months? And when do you predict school getting back to normal?
Okay, first of all, let's start with the bad news. I don't see summer camps beginning this summer. I just don't. I don't see them happening this summer. And summer camps, for them to gear up, hire staff and get going, I think they'd have to have gotten a signal from the province that they're going to allow it. And it's up to the province, because the province has outlawed it right now. And I don't think it's going to happen. Is it now? Certainly, let's watch Quebec. Quebec is preparing to reopen its schools in a very short period of time. If they see no increase in cases, then I think there's going to be pressure on the province here, on Premier Doug Ford, to open the schools by the 1st of June. That could happen. But if we see a sharp increase in infections in Quebec, forget it. I don't think there'd be any hope then of reopening the schools until September. I've heard worse predictions than that, but let's hope that by September we will have flattened the curve to the point that there's no cases happening, and why aren't we reopening the schools? Now, I think the more important question is, what will school look like when we reopen it? And I think schools are going to be very different. We're going to be practicing physical distancing. I think we're going to see, for instance, in big schools, where they might have an enrollment of 1,500, 2,000, you might have half the grades coming on one day, and then the next day, the other half of the grades, so that they would be spreading out the student body over a greater number of classrooms and practicing physical distancing within the school itself. So that's, I think, will be the bigger transformation, and I think that's going to remain in effect probably for the next 2 or 3 years.
And then taking a step back to takeout again. How long would a virus live on the takeout container? So someone says, yes, I'm going to Chan, and you get your styrofoam containers, your paper containers. Do we wash them down when we bring them home?
So there have been studies that have looked at how long virus can remain alive. on different surfaces. On plastic surfaces, probably a day or two. Cardboard, the least. Cardboard is porous, and the more porous it is, the less likely it is to survive in that environment. Probably a few hours. Metals, some metals can be 2 or 3 days. The exception is copper as a surface, and the reason why copper is less likely is that the copper contains antiviral properties that actually kill the virus. So actually, it doesn't last as long on a copper surface. But you're going to wipe them down anyway. Remember, you're not trusting like we've already answered that question by saying you're going to wipe the surface down with an alcohol or bleach rub.
What is your prediction for air travel at this point?
My prediction for air travel. Well, air travel better get going, or there's a lot of airlines that they're going to remain in serious trouble. They've laid off huge numbers of their workforce. You know, I think that air travel will resume, but once again, they're going to try to practice physical distancing on planes. I think that you know, it really depends on why you're traveling. I say that as somebody who speaks right across Canada and parts of North America, giving speeches, and every one of my speeches has been canceled. And so you may see people saying, "Hey, why are we paying so much money to bring people into one space?" Because, you know, that's part of the problem. Like, why are you traveling? Are you traveling? Now, there'll always be urgent reasons to travel. You know, for instance, for medical emergencies and for other kinds of urgent situations, or because you're an essential worker and you have to be able to, you know, you live in Newfoundland and you have to be able to get to the oil patch in Alberta, so you have to fly, you're not going to drive. And so, you know, there will always be a basic level of travel for essential workers and for essential reasons. But don't be surprised if people start taking a look at why we travel, and maybe we're treating it as a kind of a perk or a luxury when we should take a close look at why we're traveling. And just keep in mind that those planes which were packed with passengers in the past cannot be packed with passengers in the new normal in the near future. And so they're going to have to find an economic model that allows them to fly those planes with half or a third of the number of passengers of what they had before. And I'm not an economist, and I don't know how they're going to do that. I think that's going to be a real issue for them.
Okay, so we're getting towards the end of our time, so we'll answer maybe 2 or 3 more questions. Can you comment on what Sweden's been doing and their approach to herd immunity and being a little less stringent?
We have in Sweden a fascinating experiment. And I know people have talked about this from time to time. Why don't we just let everybody get infected? And it's kind of a Darwinian, you know, survival of the fittest kind of argument. And I like to think that I think we made the decision we did because we wanted to reduce the number of people who would unfortunately, God forbid, pass away from coronavirus. And I think we made the right decision. Sweden has taken a largely different approach, not completely different, because I think it would be misleading to say that they've been completely different. They have decided in Sweden not to close every business, not to close every restaurant, to prevent teenagers from going to school, high school, but secondary school, but not prevent kids under the age of 11 from going to middle school and to elementary school. And the principle there was that they were going to build up a larger percentage of the population who's infected, and therefore increase the herd immunity. And you know, the rationale for vaccinating everybody against the measles is to raise the herd immunity. So that means that if, in this case, if coronavirus arrives in Sweden, it means that there'll be fewer people to infect in the months ahead, and therefore they'll be less likely to have outbreaks of coronavirus. They have paid a tremendous price for that. They've kept their economy going, which is good, but they have a disproportionate number of deaths. And it's really for our society to decide, is that the kind of country we have? And I'm just telling you that there's 2 ways of approaching this. And you know, there are, although some people look to Sweden and say that's a really good idea. Within Sweden itself, a lot of people are critical that they did that, especially people who've lost loved ones as a direct result of COVID-19. It's an experiment I think has very important implications for us, at least until we have a vaccine. Once we have a vaccine, then we will increase herd immunity by vaccination, not by infection.
For the last couple of weeks, well, a couple of months now, when you think about it, we've been doing more services online. And we invite everybody to like and subscribe and follow what we're doing so that you can see our services. But how much longer will this go on? When will people get to be back in shul?
And I think I think we're all fervently hoping that please God, by the high holidays, we'll be able to congregate together. I think to do that, again, we're going to have to follow the advice of public health. And really, I admire what synagogues have done in being responsible and setting a good role model, even though it hurts. It hurts really deeply to do that. It hurts on an institutional level, and it hurts in exactly the same way people have been hurt by not being able to see their loved ones in hospital, in long-term care facilities, except through a window. So when will it be time to do that? As I've already said, I think around the time that schools are being reopened, there will be some pressure to open synagogues, albeit under controlled circumstances with much more physical distancing than usual. And we're all going to have to find a new way of greeting each other without shaking hands or hugs or things like that. And I think you may see some face masks in the synagogue. But please God, we will all be together and able to worship in synagogue sometime really, really soon.
Okay. So even if we return to a new normal that will include face masks or gloves or lineups, this can get really, really hard and really tiring and wear on people mentally. What do you suggest people should be doing to make it just a little bit easier?
I think that's I'm going to proffer some advice. I don't always follow my own advice. I run 3 times a week, 10 kilometers at a time. And I've often said, I say to my partner, Tamara, it's the only time I feel normal in the wake of that. I think that we all need to believe that this will pass. And until it passes, to take care of ourselves, to nurture ourselves by reading books. I'm a big believer in sitting outside and looking at nature, just taking small pleasures, being mindful, breathe, make sure that you breathe, make sure that you practice gratitude, that you notice the things that you're grateful for. Look out for people in the neighborhood who you know are lonely or who maybe aren't taking as good care of themselves because of physical distancing and they're isolated. If you do those things, I wrote a book about kindness and you need to be kind to yourself, but from that will come being empathic and kind to other people. And if you do that, then we will ride this out together. And I guess the last thing I want to be able to say is that truly we are in this together. So the more we think of it that way, the more we'll get through it.
Okay, that's terrific. We thank you so much for your time. I'm gonna
Sarah,
I think we just lost you, but we'll turn it over to Rabbi Cutler for some words.
All right, thank you so much, Phil and Sarah.
back over to Rattler if he's ready.
I am here once again. Thank you so much, Sarah and Phil, and especially thank you so much, Dr. Goldman. As always, you have enlightened us and shared the information with us in a straightforward fashion, which is also mixed with hope and your signature kindness. So thank you so much for that. And I want to remind everyone who is with us this evening, your clergy is here for you. Of course, we can't offer medical advice, but we are here to be with you through this crisis, to offer you spiritual care. Thank God we are all healthy. We have members of our community who are certainly suffering. And I like to think that we've been able to help them, and we are here to help you. So please, please do not hesitate to reach out to us as we reach out to you, whether you choose to call or email or any other means of communication. Dr. Goldman, I want to turn back to you for a moment. Your parents, Sam and Shirley, were fixtures at Adath Israel for decades. Your father was a lifetime trustee after serving on the board for many, many years. I know that you are in the process just now publishing an ebook in time for Mother's Day, and I think it'd really be of interest to those who have tuned in tonight. So hoping you could share with us just a word or two about that.
Yeah, it's a pretty incredible story. It's the story of I think a lot of people who remember my parents, Sam and Shirley, and they passed away in 2013 and 2014, and a lot of people remember that my mom had severe dementia, and my dad took exquisite care of her until he could no longer take care of her. And when she was in long-term care, it broke his heart, and then his health started to go downhill. I wrote a story, it's an essay, about the incredible events that occurred after my father had died, but before my mother had died, and in particular, what happened on the last day of her life. It's a pretty extraordinary story. It's one that will test your belief, but that's the point. And it's called The Last Kindness, and it will be available on Amazon as an ebook. And for the next week, it will be available free of charge. And not that it's expensive in any case. I think it's 99 cents, but it will be free of charge until Mother's Day. And if you knew them, you'll like the story. But because there's a lot of references to Adath Israel. But if you didn't know them, the story, believe me, is extraordinary, and it's all true, and it really happened.
Once again, Dr. Goldman, thank you so much for being here. Thanks to all of our viewers for tuning in. We have a great array of programs coming up at Adath Israel, so please stay tuned to your Achshav, which arrives in your email twice a week. If you're not receiving our emails, please let us know as soon as possible. Check our website regularly. We have some fantastic speakers coming up for our online Sunday evening speaker series. We're just finalizing the details in a couple. But this Thursday evening, we have a great program with Tanya Connor-Green, Grow the Business You Always Wanted. Tanya is the wholehearted business coach. I encourage everyone to tune in. Thanks so much for being here. Thanks once again to Dr. Goldman. Please, everyone, stay home, stay safe, stay healthy, and we hope to see you all as soon as we can when it is safe to do so. Have a great night.